In this channel we offers you a deep dive into the world of medicine and healthcare, where insightful perspectives, medical updates, and expert insights are shares. Join the journey to gain a better understanding of various health topics and stay informed with the latest medical breakthroughs. Today we will discuss about seizures in children. Presenting complaint, seizure. History of present illness. Onset, when did the seizure episodes begin? Was it sudden, or were there warning signs? Duration, how long did each seizure episode last? Description, can you describe the convulsions? Note any abnormal movements, posturing, or changes in consciousness. Triggers, were there any specific triggers or events preceding the seizures? Frequency, how often do the seizures occur? Progression, have the seizures changed in character or frequency over time? Recovery, what happens during the postictal phase? How long does it last? Associated symptoms. Aura, any premonitory signs or warning symptoms before a seizure? Incontinence, is there loss of bladder or bowel control during seizures? Tongue biting, any evidence of tongue biting or injuries during seizures? Past medical history. Birth history, any complications during pregnancy, delivery, or neonatal period? Developmental milestones, is the child meeting age-appropriate developmental milestones? Illnesses, any history of febrile seizures or other illnesses affecting the nervous system? Medications, list current medications, including anti-epileptic drugs if prescribed. Family history. Seizures or epilepsy, are there any family members with a history of seizures or epilepsy? Neurological disorders, any family history of neurological conditions? Social history. Environmental exposures, any exposure to toxins, lead, or substances that might contribute to seizures? Family dynamics, are there stressors or significant changes in the family environment? Review of systems. Headache, any recurrent or severe headaches? Neurological symptoms, any other neurological symptoms like weakness, sensory changes, or visual disturbances? Physical examination. Vital signs, note any abnormalities in heart rate, respiratory rate, or temperature. Neurological examination, assess for focal neurological deficits, abnormal movements, or signs of increased intracranial pressure. Skin examination, look for any cutaneous stigmata that might suggest an underlying genetic or metabolic disorder. Diagnostic evaluation. Electroencephalogram, has the child had an electroencephalogram to assess brain activity during and between seizures? Imaging, consider brain imaging MRI or CT to identify structural abnormalities. Laboratory tests, evaluate electrolyte levels, lumbar puncture and cerebrospinal fluid analysis, blood glucose, and other metabolic parameters. This comprehensive history can assist in determining the cause of the seizures and guide further diagnostic and management steps. In the second part, we will discuss about comprehensive guide to clinical presentation, diagnosis, and management. Introduction. Convulsions in children can be a distressing experience for both parents and healthcare providers. Understanding the clinical presentation, diagnosing possible etiologies, considering the differential diagnosis, conducting thorough investigations, and implementing appropriate management strategies are crucial aspects of approaching a child with convulsions. Clinical presentation. Convulsions in children are often characterized by sudden, uncontrolled movements and altered consciousness. Observing and documenting the details of the seizure episode is essential for accurate diagnosis and management. Key aspects to note include the duration, type of movements, postictal state, and any associated symptoms such as fever, vomiting, or abnormal behavior. Diagnosis of possible etiologies. 1. Febrile seizures. Common in children aged 6 months to 5 years. Typically associated with a rapid rise in body temperature. Diagnosis often clinical, focus on identifying the cause of fever. 2. Epilepsy. recurrent seizures not triggered by fever or acute illness. Detailed history, EEG, and neuroimaging play a crucial role in diagnosis. 3. Infections. Meningitis or encephalitis and cerebral malaria may present with seizures. Lumbar puncture, blood cultures, malaria parasite and imaging aid in identifying the infectious agent. 4. Metabolic disorders. Hypoglycemia, electrolyte imbalances, or inborn errors of metabolism can provoke seizures. Blood tests to assess glucose, electrolytes, and metabolic markers are necessary. Differential diagnosis. It's vital to consider various conditions that may mimic seizures, such as 1. Breath-holding spells. Typically occur in response to frustration or pain. Benign and self-limiting. 2. Syncope. Loss of consciousness due to transient decrease in blood flow to the brain. Differentiated by the absence of abnormal movements during the episode. 3. Psychogenic non-epileptic seizures. Mimic epileptic seizures but are psychological rather than neurological in origin. Video electroencephalogram monitoring can aid in distinguishing psychogenic non-epileptic seizures from true seizures. Investigation. 1. Electroencephalogram. Crucial for diagnosing epilepsy and characterizing seizure types. Helps in differentiating between focal and generalized seizures. 2. Neuroimaging. MRI or CT scans to identify structural abnormalities or lesions in the brain. Essential for ruling out intracranial pathologies. 3. Blood tests. Comprehensive metabolic panel to assess electrolytes and glucose levels. Specific tests based on clinical suspicion like genetic testing for metabolic disorders. 4. Lumbar puncture. If meningitis or encephalitis is suspected. Analysis of cerebrospinal fluid provides valuable diagnostic information. Malaria parasite in case cerebral malaria is suspected. Management. 1. Acute management. Focus on ensuring the child's safety during the seizure. Administer anti-epileptic medications if the seizure lasts longer than 5 minutes. 2. Long-term management. Tailored based on the underlying cause like anti-epileptic drugs for epilepsy. Addressing and managing any identified etiologies as treating infections or metabolic disorders. 3. Educating parents. Provide information on recognizing and managing seizures at home. Emphasize the importance of medication adherence for children diagnosed with epilepsy. Conclusion. Approaching a child with convulsions requires a systematic and multidisciplinary approach. From understanding the clinical presentation to conducting thorough investigations and implementing appropriate management, healthcare professionals play a crucial role in ensuring optimal outcomes for these young patients. By combining clinical expertise, diagnostic tools, and effective communication with parents, the goal is to identify the underlying cause and provide comprehensive care for children experiencing convulsions. We will end with a case history of a 3-year-old female who presented to the emergency department with complaint of convulsion. History of present illness. The parents report that she experienced a sudden onset of convulsions at home. The convulsion lasted for approximately 5 minutes, during which her body stiffened, and she had rhythmic jerking movements. No known trigger or fever was noted prior to the episode. This is the first time she has experienced a convulsion. Past medical history. She has a history of recurrent ear infections treated with antibiotics. No history of seizures or neurological disorders. Up to date with routine vaccinations. Developmental history. She has been meeting developmental milestones appropriately for her age. No concerns raised by parents regarding her cognitive or motor skills. Family history. No family history of epilepsy or other neurological disorders. No consanguinity reported. Social history. Lives with both parents and older sibling. No exposure to toxins or environmental hazards at home. Paraclinical investigation. 1. Physical examination. General examination revealed a well-nourished child with no signs of acute distress. Neurological examination showed no focal deficits. 2. Blood tests. Complete blood count and electrolyte levels within normal limits. C-reactive protein normal, ruling out acute infection. 3. Lumbar puncture. Performed to rule out central nervous system infection. Cerebrospinal fluid analysis showed no evidence of infection or inflammation. 4. Malaria parasite done to rule out cerebral malaria was normal. 5. Electroencephalogram. Conducted to assess brain wave patterns. Showed abnormal epileptiform activity, supporting a diagnosis of epilepsy. 6. Imaging. Brain MRI to rule out structural abnormalities. MRI revealed no significant abnormalities. Diagnosis. She is diagnosed with febrile seizure. Given her age and the absence of fever and other concerning features, additional investigations for epilepsy are recommended. Management of a child with convulsion, specifically in the context of a febrile seizure, involves several key components. 1. Febrile seizure management. Given that her convulsion occurred without a fever, it's important to identify and address any underlying causes. In cases of febrile seizures, management may focus on treating the underlying fever with antipyretic medications like acetaminophen or ibuprofen. Educate parents about fever management, emphasizing prompt use of antipyretics and maintaining adequate hydration. 2. Antiepileptic medication. If further evaluation reveals a diagnosis of epilepsy, the initiation of antiepileptic medication is often necessary. Selection of the specific antiepileptic drug depends on the type of seizures, the child's age, and other individual factors. Adjust medication dosages based on the child's response and any observed side effects. 3. Seizure precautions. Instruct parents on safety measures during seizures to prevent injury. Recommend placing the child in a safe area, removing potentially harmful objects, and turning the child onto their side to prevent choking. Advise on positioning to maintain an open airway and the importance of not restraining the child during a seizure. 4. Education and support. Provide parents with information about epilepsy, including its causes, potential triggers, and prognosis. Offer resources and support groups for parents to connect with others facing similar challenges. Encourage open communication with healthcare providers to address concerns and receive ongoing guidance. 5. Follow-up care. Schedule regular follow-up appointments with a pediatric neurologist to monitor the child's response to medication. Adjust the treatment plan as needed based on seizure control and any side effects. Monitor developmental milestones and address any concerns promptly. 6. Family counseling. Consider involving a pediatric psychologist or counselor to help the family cope with the emotional impact of having a child with epilepsy. Provide resources for parents and siblings to better understand and support the child with epilepsy. 7. Long-term monitoring. Perform regular electroencephalograms and imaging studies as needed to assess the ongoing status of the child's epilepsy. Adjust treatment plans based on the child's developmental progress and any changes in seizure activity. It's crucial to tailor the management plan to the individual needs of the child and involve a multidisciplinary team, including pediatricians, neurologists, and other specialists, to provide comprehensive care. Regular communication between healthcare providers and parents is essential for effective management.